at CHEO, so Children's Hospital of Eastern Ontario. And we're going to be sharing some lessons learned and insights that we have discovered so far working together on a project at CHEO. And I guess I should introduce myself. I'm Dr. Vivian Lee. I am an assistant professor in the Department of Psychology at Carleton University and a KBHN-funded researcher. So welcome, thank you for coming to our session, and we'll get ready in about 3 minutes.
All right, so if we're ready to get started, I'll just jump right into it. I'm Dr. Scott Robson. I'm here today from the CHEO Research Institute and the Knowledge Institute on Child and Youth Mental Health and Addictions. And today I'm going to be talking about One Call, One Click and an evaluation of that project that's going on now. So onecallonclick.ca is a regional coordinated access and navigation program. It's a service that's available in 5 counties surrounding the Ottawa area, and it services youth from the ages of birth to up to 21 years of age. And so what this means is that it is available to children, youth, their families, and healthcare providers who are trying to navigate the systems available for children, youth, and their families in mental health and addictions and substance youth health. So these systems have historically been fragmented and complex, and it's been very difficult for people to even figure out where they should start looking for help once they decide that they need it. And so while I'm helping with the evaluation of this project, I'd like to be clear that it wasn't my idea to start this thing. It was something I'm helping out with now, but it was getting it off the ground was the work of a lot of very smart and dedicated people, including Kids Come First, CHEO, community partners, families and youth with lived experience of both mental health and substance use issues and of trying to navigate those systems on their own, and people from over the 25 community agencies that help people with those challenges in the area. Since the launch of this program in 2021, One Call, One Click has served over 10,000 children, youth, and their families, and they've got multiple different streams of services available to people, including care coordination, peer and family support, even just providing information and support to people on the phone when they call in. I'm going to be talking about just a subsection of these people today, specifically the just over 6,000 people that called in and went through a full intake with One Call, One Click in the period between June of 2021, when the service began, and December 2022. So when I say a full intake, what I mean is that the client spent some time on the phone or in a video chat with an intake worker at One Call, One Click. And during this time, the intake worker would gather some demographic information about the client, including factors like their age, their gender identity, racial identity, including a number of other factors. They would gather some clinical information, including the person's reason for calling in the first place. And they would go through some clinical screeners with the person on the phone. These included the HEDS-ED under 6, the HEDS-ED over 6, the ASQ, which screens for suicidality, and the CRAFT, which is a screening tool for substance use. So not everyone would receive all of these screeners. They were sort of applied as necessary to the person's circumstances and needs. There's no wait list for this service. Someone can call in, they can speak to someone directly and go through an intake right away. You can go on the internet and schedule a time, or you can be referred by your primary care provider. So from the information provided in the intake worker can assign to the client a level of need and then use that information to select from a list of services that are available, different recommended interventions. So this includes 5 different levels, ranging from the lowest level of need, which is labeled here as general population. These are clients that they don't require any clinical interventions. They just need a bit of extra information, maybe a bit of support, some guidance going into the future, to people with severe or complex needs. These are people that require very intensive and immediate interventions. So the most common of these that we see in the population that's called in is moderate needs, which if you can read that on the screen there, you can see it includes some pretty significant interventions, including things like supporting housing, case management, withdrawal management. And nearly 75% of the people that have called in to One Call, One Click are rated at moderate needs or higher. Pardon me. So after the intake worker uses this information, they find the agency that's best suited to the client's needs and goals, and they set up an appointment for that person at that agency in the future, connecting them directly with the service that they'll need. And so this information is very useful for these people and helping match these clients to services, but it's also very useful from a system perspective. So I mentioned before that these systems have often been fragmented and complex, and that's true for the data that we had available to us as well on what the needs were inside the community, the severity of those needs, who was experiencing these needs. And so with so many people now going through One Call, One Click, we can start to get a clear picture of what the needs in the community are for child and youth mental health and addictions and substance use health. So we know that one of the major barriers to people accessing help when they need it is that they don't even know where they should go and look for help. And this is one of the barriers that One Call, One Click is best suited to helping people overcome. But there's many reasons that people don't access care when they need it. And we wanted to get a sense of whether or not the service is helping with these other barriers. So what I've got listed here are some social determinants of health, and these are non-medical factors that are nonetheless related to people's medical outcomes and health. So for the case here, we're going to be talking about racial identity, gender identity, and family income. And I want to be clear that these factors, while they're related to health, these are not things that are causal in any way. Mental health and addictions, substance use are challenges that affect everyone. But people who exist in marginalized communities often face more barriers in finding the help that they need once they've realized that they need that help. And realizing that you have a need and expressing it, that on its own is a huge barrier to overcome. And every hurdle that someone faces after they've realized that, taken that initial step, is that can be a hurdle that someone doesn't make it over. At the worst case, and they stop their journey towards getting care. Or if they get past it, it slows them down. And as I'm sure all of you know, reaching people early on is extremely important. So our questions here were to see how closely the demographics of the clients that were coming through One Call, One Click matched those of the community. So we made some comparisons with the data we gathered to the census from 2021, and we wanted to see if the social determinant factors were related at all to the level of need that people were being assigned as they came through the service. So in the blue on the graph, in the blue on the graph here, you'll see those bars represent the data from One Call, One Click clientele. The orange shows the data from the census. And so we can see that the proportions of people that are coming in are pretty similar to those of the community, but not an exact match. We'd expect to see about 70% clients who identify as white based on community demographics, but based on this, we see it's a little bit closer to 75. And likewise, we'd expect to see more folks from other racial groups than we actually do. We look at gender categories, we see something else as well. Female clients are more common amongst the client base than you'd expect from community levels, and that's true as well for non-binary people as well as transgender individuals who are contacting One Call, One Click in higher proportions than you'd expect. Looking at family income, we can see that we have a lot of extra clients that are in the very low income range, people whose family income is below $30,000 a year. Because we serve clients at a college and university age, I thought that that might be an explanatory factor, people who were living independently, going to school, but looking at the data, that actually isn't the case. That's not who's making up that group right there. Moving on to looking at how these factors relate to the level of need that people are experiencing, we don't actually see any relationship at all between racial identity and level of need and gender identity, or level of need and family income. So there are some limitations to what we were able to do here. For instance, we don't run the census, so there's some differences in the questions that are asked through the census and the questions that are asked by people, the intake workers at One Call, One Click. So for instance, the census doesn't include an option to say that you don't know or that you prefer not to answer. And these are commonly chosen options for clients at One Call, One Click. It's very frequent, for instance, that the kids that are calling in don't know how much money their parents make. And for some population categories as well, people could answer in ways that weren't available on the census, for instance, indicating that they're two-spirit individuals or asexual. And for racial background, people could indicate multiple racial backgrounds when they call into One Call, One Click, whereas on the census, you're able to provide one option. Another limitation is that we're only talking about the youth population of Ottawa, whereas the census covers everyone in the area. And another big thing that is sort of reflective of the benefits of One Call, One Click is that because we now are able to see this data for the community needs and the severity of needs in a way that we couldn't before, it means, unfortunately, that we don't have anything to compare it to. We can't say if we're doing better than before or not. All we can say is what's going on right now and how it's reflected against the community as it is. So in conclusion, we can say that One Call, One Click we've been able to reach some people that were traditionally marginalized along gender and income groups. There's still some work to be done with reaching out to people from different racial communities, it seems, but yeah, and we see no relationship between the social determinant of health variables and the level of need that people are experiencing. And so I'd like to thank you all for your attention and the people up on the slide there for their investment in this project. Thank you. Do we do questions now or after? Sure. Yep. So the question was about whether or not we're able to match postal code to people's, and looking at census data through those means. So we do have the last 3 digits of people's postal codes, but we haven't got into those analyses quite yet. We want to be careful not to do anything that would be identifying or anything along those lines. So, but yes, that's an interesting avenue for looking at things in the future. Are there any other questions? Okay, well, thank you very much.
Hi, everybody. Can I get my slides up, please? Okay, good afternoon, everybody. My name is Maria Rogers, and I am a clinical psychologist and an associate professor at Carleton University. And I have to say it's my first time at this conference. I feel very lucky that it's in Ottawa this year, and it's been great to be here at the Kids Brain Health Network. Before we begin, I would like to first acknowledge my co-authors on the study that I'm going to be presenting today. This is a multi-site project, and we have a number of different researchers across the country as well as community partners. And I want to point out 2 community partners in particular who've been pivotal to this research, and that is CADRA, which is the Center for Canadian ADHD Resource Alliance, as well as the Center for ADHD Awareness Canada. All right, so studies have shown that families with a member who has been diagnosed with ADHD experience higher levels of stress and disruption in their daily routines compared to families without ADHD. And there have been literally decades of research on this topic, and we know that having a diagnosis of ADHD in a family can greatly impact family functioning overall. Other studies have shown that this is quite a strain on relationships as well as day-to-day functioning, but also relationships between parents and children and between partners and parents as they navigate the challenges of managing a diagnosis of ADHD. Despite a lot of research, as I mentioned, decades of research on family functioning in children with ADHD, a gap remains in the literature, and that is that we have not typically been asking families about their perspectives on the future of the research of children and families with ADHD in this country. So we've been doing a lot of research on families, but we have not been doing a lot of research with families and asking them about what they would like to see in the future of research in this country. So we wanted to directly engage with families for this study to help determine the focus and the scope of what the future of ADHD research should look like. So this led us to a project, what we refer to as the CAPS project, the Canadian ADHD Priorities Study. And this study marks the beginning of a collaboration aimed at understanding key themes and priority issues for ADHD research in Canada according to key stakeholders. So researchers, but as well as clinicians, educators, advocates, policymakers, and families. So today I'm going to talk about the results from the beginning of this study, looking specifically at the family data. As I mentioned, our primary partner is we have two national ADHD organizations that we've been working with. Our primary partner is the Centre for ADHD Awareness Canada. Some people would know them as CADAC, which is a national nonprofit organization committed to enriching the lives of families affected by ADHD through advocacy. And CADAC assumes a significant role in shaping national policy and funding decisions related to ADHD through the dissemination of research, policy papers, white papers, advocacy statements, and so on. And CADRA, our second partner, as it's widely known, serves as a resource organization on ADHD for healthcare providers. So throughout the years that many of us in Canada have been doing ADHD research, we tend to get together once a year at the ADHD Research Day conference. For those of you who may be interested in ADHD research, we meet once a year. And a consistent topic of discussion at these conferences has consistently revolved around sort of what is the future of research on this topic? How can we address the concerns of various stakeholders in this field? And as I mentioned, historically that has included researchers only. We would like to know now more from a broader array of stakeholders in terms of priorities for research. And that's important for advocacy when we're talking about ADHD in terms of government, whether we're talking about research funding, financial aid for families, the push for inclusion of psychological services in healthcare, and so on. So through discussion at these conferences over the last few years, we decided to embark on this project, which I'll present some of the initial findings today. We surveyed about 1,400 people for this study. As I mentioned today, I'm just going to present the results from the families data, which was approximately 600 families. We used the Delphi method, which, for those of you who are perhaps not familiar with the Delphi methodology, the Delphi method is a systematic way of iteratively collecting data from a broad range of experts to arrive at a consensus or a set of conclusions. So within this project, we used an expanded term of experts. Again, historically in Delphi studies, we tend to refer to experts as clinicians, researchers, medical providers. We broadened the term of experts so that we would also include families as experts in this study. And when we're implementing a Delphi study, we typically engage in 3 distinct steps. So initially, the first step is a starting survey, which is created with the help of a group initially, often using research from existing research, previous similar studies, or personal experiences. So in this case, we consulted the research. We also consulted with our 2 partnering organizations to sort of cast a wide net to come up with a list of ADHD research priorities. Step 2 in the Delphi method involves kind of consolidating and combining these responses, looking for common grounds, and asking for additional explanation when needed. And then we send the revised survey back to the same group of experts and stakeholders to get their perspectives a second time. And then this process continues iteratively until a unanimous viewpoint of consensus is agreed upon. So for this study on ADHD research priorities, we started this data collection in December 2022. We distributed a survey across a number of different email lists across the country, including CADAC's membership, which is a very large membership of people with ADHD across the country. And our focus was on Canadian priorities. So the survey was specifically aimed at individuals residing in Canada. And the survey included questions about demographics as well as an open text box for anything that was not captured in the initial set of questions. So this would just be an example of a question. So for example, one item could be providing access to resources and services in rural communities, and then each respondent would indicate how much of a priority they felt that this particular item was, from 1 being not a priority to 2 being a critically important priority. From wave 1 of our study, so at this point we've now collected data on wave 1. Not surprisingly, we had a lot of primarily women participated, and again, these are mostly parents of children with ADHD, so historically in the parenting literature, we tend to have an overrepresentation of mothers. Our wave 1 sample consisted primarily of people in between 40 and 59 years of age. And the second group was 25 to 39, so again, fairly representative of a sample of parents in Canada. And the large majority of our sample was from Ontario, British Columbia, and Alberta. And although we did have representation from all the provinces and territories, it was considerably lower in other areas. And although the survey was distributed in both French and English, we did not have a high representation from Quebec. So when we're doing a Delphi study, we get back all of the responses, and we look at descriptive statistics like I've just shown you and others, but then we're mainly looking for the level of agreement from the various stakeholders in terms of the priority areas. And typically we're looking for about a 70% or higher priority according to the Delphi methodology. So this is our initial set of data that we received back, indicating that there were 16 items that were considered there was over 70% consensus or agreement on in terms of priorities from families. And these priorities could be categorized into 3 sort of common themes among these different items. So when we look at the top priorities, they fall into 3 categories. So enhancing awareness and education. So for example, increasing knowledge about ADHD in the school system, as well as with parents, increasing understanding of ADHD in the workplace, as well as increasing our understanding of ADHD among just the general public. The second theme that emerged was improving access to services, and this was actually our top priority items, so providing access to ADHD services, providing access to healthcare providers who are well-trained in ADHD, as well as providing access to support for families, so things like family support and respite. And then the third theme in this initial wave of our study was advancing diagnostic practices and research. So things like understanding complexities of ADHD in research design, so for example, comorbidities, how ADHD is understood and diagnosed in girls, what is meant to be impaired by symptoms of ADHD, that was one that came up quite a bit, and then research that impacts families. So we've now launched wave 2 of the study, so that was our initial results. As I mentioned, in a Delphi study, we then take those results and we send them back to the participants, and we ask them again to rank the revised list. We also took the open text responses and created new items based on the responses from families. We've now, as of last month, we've now sent out the second wave of data collection with some additional items, and are looking forward to getting those results back as well. So we're only partway through this study. As we continue to work towards a consensus, we will be continuing to examine wave 2 data as it comes in. Wave 3 will be a much shorter survey, really pinpointing the top priorities, critical priorities for research. And stay tuned for the final results. Thank you. Happy to take any questions, if there are any. Okay, thank you so much.
Testing? Oh, mine works.
Mine is not. Oh, there we go. Hi. So for the next little while, for the next few minutes or so, what we are going to do, Jess and I are going to co-present. We're very casual. That's why we're sitting on the throne seats. And it's more of a conversation, really, than a presentation, but we will show you the project that we're working on. So we'll be co-presenting work that we've been working on evaluating the Secret Agent Society small group program. So if you've been watching some of the videos, there's been a video with one of the families that was part of our program with Abby and Kai in a different iteration, a different trial. So that's the program we'll be talking about. This is research that is ongoing right now in Ottawa that I'm conducting at different sites, and we'll talk a little bit more about that. But I thought that for today, what we'll do is I will introduce to you the Secret Agent Society in a few minutes, but what we're going to talk about is more about the adaptations and the decisions we've had to make about these adaptations as we're working to deliver evidence-based manualized intervention in community-based settings. So as we're coming out of the pandemic, there have been a lot of adaptations that we've had to make to accommodate families. As much as we want to have evidence-based, manualized, everything by the book interventions, sometimes in real life that doesn't happen. So Jess and I have done a lot of problem solving to try and incorporate and engage as many families as we can from a diverse population. And when we say diverse, we don't necessarily just mean ethnically or linguistically or culturally diverse families, but these are families in the real world, right? Families who may have multiple kids, who have difficulties engaging in multi-week manualized interventions. These may be separated families or families of parents who may be struggling in one way or another. So we're going to talk a little bit about how we're adapting our program and figuring out how to work with them. Yeah. Are you ready?
Ready.
Okay. So, there we go. All right. Is it gonna go? Okay. So, show you a little video.
Years 2030, and soon after birth, all children undergo a genetic screening procedure known as career determination testing. Your CDT results have shown that you are best suited to a career as a special agent. Please enter the International Secret Agent Society headquarters, where you will begin your training.
To successfully graduate from this academy, you will need to complete a 3-level program that teaches you how to decode people's thoughts and feelings. Good luck.
That's a little video on the Secret Agent Society small group program. So it is a program, a behavioral program, a social-emotional behavioral program that is used to support children and youth on the spectrum who are struggling with emotion regulation and social skills difficulties. It is an evidence-based program. There have been multiple randomized control trials. And as you saw in the video, it's SPY-themed. It's typically run as a 10-week program where there are parent groups and child groups. And it includes first-person video games where children go on a mission together, they role play, they participate in exercises. Anything else?
They solve missions.
Solve missions, yep. It's a really quite interactive game. And if you want more information, Melissa, our regional rep, is sitting right there.
I think one of the greatest things too is, as much as it's a video game, there's the gadget pack, so you can have hands-on, malleable stuff that you can play with. You have the cards, you have the gadgets, you have the kits. So there's the handheld package that comes with it as well.
That's
so you
right.
can turn it very real life.
Yes, and families do quite like that. And the reason why we have that is so that they can bring it with them wherever they go. So they can bring it to school, they could bring it to the playground. They don't necessarily need to be attached to a computer or a technology in order to access the different strategies that the program teaches. So, So right now, I've partnered with 4 different community-based mental health and developmental service providers to deliver the Secret Agent Society small group program in Ottawa, CHEO being one of the sites. We have trained, to date, 41 therapists to deliver the program. We're ensuring that it's sustainable so that once they're trained, they can continue to provide this program. So once this research program is complete, CHEO and all the rest of the sites can actually continue to deliver the program if they choose to. Hopefully you find it useful. And our goal is to recruit 108 families over 24 months. So we've already started. It's already been a year. So we have another year to go. Currently, we have 57 families that have been enrolled, and recruitment is ongoing. So we'll have a next cohort of families starting in January. So just to give you a little bit of information on how we run the program, the research as well as the SAS program. So we recruit with CHEO. So you have your list, you go through, and you determine the families that you think might be beneficial for them to participate in the program.
So we get names from some of the clinicians that are working with clients already, and if they deem that they're a good fit, they put them on our list, and from that list, looking at the file and their skill sets, we put them into groups that would fit well together.
Yes, so there's a lot of decision making about whether different individuals or different families will fit well together as a group. So once they are recruited, the names get sent to me and my research team sitting right there, Jennifer and Rachel, who help out with the program. We interview the families, we have them fill out surveys, and once they have been consented, we send them back to CHEO and they participate in a 10-week program. And we're going to talk a little bit about how we deliver that, because since the pandemic, there have been different modalities that have been used to deliver some of these programs, and we'll talk about some of the advantages and maybe challenges that we've had in trying to figure that out. Once the family is complete, have finished the program, they participate in a feedback session where we have interviews with them, and they also, of course, fill out surveys again post-intervention. And then they come back for a 3-month booster session with CHEO and a 6-month booster session. That's pretty good, Tess? Mm-hmm. And data collection is ongoing. So we're just going to talk about some of the adaptations that we've made. So I talked briefly about the modalities that we have encountered. So at first, when we first started in January 2023, so earlier this year, we were still in that weird time where we had to do some virtual. We were starting to bring back in person, but we thought virtual delivery would be best. And so we had families participate via Teams or Zoom, and they were actually at home.
And I think the biggest advantage from that first group is that we began with a smaller pool, or we had less participants on our list, and they were all over the city. So to be able to bring them into best fit groups, that virtual option fit them best. So we didn't have to have families driving in from Rockland at the same time as driving in from Ottawa. So that first group fitting virtually was definitely ideal. Yeah,
so this was a more diverse group. These are families who said, well, I really want to participate, but it's so far, I'm not sure I can actually do it, but offering it virtually, if they just had to go home and not drive an hour into the city, that worked really well for them. But we know that virtual delivery of school or interventions does not work for all kids or families. And so there were a number of families who said, well, that's not going to work for us. Let's do it in person. Let's wait. So the next iteration, we actually had in person as well as virtual.
It was a hybrid. So one of the things we were able to do for the initial virtual is we tried virtual with one family. There were other siblings in the house. Mom was a single parent. It was really challenging to have, and it was really challenging for the parent to have the child engage.
Yes, yeah.
With the video and the therapist at the time. So we were able to be flexible enough to bring that one client to continue to participate virtually, but at our site. So our therapist was on site. That child came on site, still participated with his group virtually because everyone else was virtual. But we were able to bring it out of the chaos of the home environment sometimes and be able to still have them participate in person. Or still participate virtually, but at a different location where we were able to get more of that therapist support.
Yes,
in participating in the activity.
I do want to highlight that this is a flexibility that CHIO was able to deliver that the family was participating virtually first, and then the in-person worked a little bit better just because we know that it's very intense at times. The child has to be engaged and the parent has to be there, but if the parent can't, then it's really not beneficial to them. So there were a lot of considerations. We had to problem solve around that quite a bit. Right. And I'm getting the signal that we have to move on to the next person, so we're going to go faster. So
our next group was hybrid. And
hybrid,
I think what was really great about the hybrid is for those child participants that participating in an activity virtually is hard. We brought them in person, but for the parent component, they were able to stay virtual. And that was really, really helpful, especially because we were having separate sessions. So rather than having parents come to our site twice, once for the parent or for the child component and then again for the parent component, being able to have the parents do the virtual in-home was really helpful.
And I think that speaks to the flexibility of SAS small group, right? That you can have different modalities. The kids can be the kids can be in person because that works better for them, but for parents who can't drive all over the city and may actually benefit from just a virtual meeting, that worked really well for them. So again, we've worked hard with the parents. We've asked them what works best for them, and we've adapted how we deliver as best as we can to keep the families engaged, which I think sometimes some agencies might be hesitant to do that. But we are still sticking with our curriculum and ensuring that we're delivering everything as it was meant to be delivered, but just changing the modality to fit the family. And then very quickly, I just wanted to highlight that we're making adaptations for our Francophone families. So in Ottawa, some of you may know we have quite a large Francophone community, but a lot of the interventions that we offer are in English, and so exclude many of the families that only speak French. And so working with CHIO right now, we've adapted manuals, programs, slides, scripts, everything. We also hired research assistants who speak French and can deliver the consent as well as the focus groups in French. And so we're trying to include them as much as possible to really work with them and build that relationship with that community so that we can continue to deliver high quality care for them.
Yes, we have our first French group running, I think, right now.
That's right.
Bilingual group. And we learned that from one of our first groups. We had at least 2 families who were bilingual, but primarily French. And our therapist just mentioned that it was just so much easier for her to share the information to these 2 clients.
That's right, in French. Yes.
Even if everything else is in English, being able to play the game in English, that worked out perfectly fine, but that some of the explanation needed to be done in French. And so we were able to adapt that to run a group now that is in French. So all of the instructions, delivery, and everything is in French.
Yeah, so we're very excited to see the outcomes of that. And I just wanted to say thank you to all my collaborators, all of the sites that are running the study right now, to Jess, who is leading the group at CHIO, and the families who are so willing to give their time and participate in our research. So thank you.
Thank you.
Any questions? I know we have to move on to our next discussion, our panel. Yes, Maria.
So I noticed that some of the barriers that you discussed for families was sort of about getting to CHIO or to the sites. I was wondering if you had any plans to do like more community-based data collection in sort of some more rural areas or some of the areas surrounding Ottawa.
Yeah, so Connect Well, that is another mental health developmental service agency. They're based more in Brockville, like more in the rural areas. So we're actually working with them to connect with those families and try and build up their technology use and provide more technology for families who are in more rural areas. Who would never be able to drive in and access those services. So we're very excited about that.
Awesome.
Thanks, Maria. I think we're good. Do you want to come up and set up for the next group? Okay. Thank you.